So now if we come to more specific CAR T cell studies, the J&J 4528 was presented here by Dr. Madhuri, and it was CARTITUDE-1 study.
Right.
Would you like to update briefly on what was mentioned? Main first thing is anything about this CAR T cell would be important, and we discussed about that this targets two areas.
Yeah, exactly.
So that's a little bit different than the other one.
Than the BB21 and several other CAR Ts that are in development right now. I think the most exciting part of this is that this was the CAR T that actually kind of woke us up 2 years ago at ASCO when this construct done in China showed some amazing results. But at that time, the concern, at least in the US physician's mind, was those patients had not had as many treatments prior and as many relapses prior to getting CAR T as we see in our patients. So they were a little bit earlier relapse patients, potentially more respondable patients. So we were wondering how that would function for our US patients. And I think with Dr. Madhuri's presentation this morning suggests that the response rates are fantastic even in the United States population. And I think the key is what you just pointed out. It's a bivalent binding, and that may be causing more responses in these patients, which tighter bind. And one of the unknowns, which I don't know the answer to, is the immunological synapse created between the CAR T and the target, and the distance between the molecular distance is one of the factors that people have postulated makes a difference.
And so efficacy-wise, it's amazing. It's close to 100% responses.
Absolutely.
Almost everybody responds.
They presented 29 patients, and all of them had a response.
So I think that's very, very encouraging. And this is in a setting where patients have had 5 and more lines of treatment.
Median was 5, and they were up to 11 and 13 patients.
Yes, so heavily pretreated patient population. You and I know these patients do not respond to anything else. So it is in a setting where any other treatment would have 2 months of response, and the proportion of patients getting response would be exceedingly small. So that's the good part. Toxicity. Now, you mentioned and you have experience with CAR T cell in lymphoma and leukemia, and so you're very familiar with it. And this is where in lymphoma leukemia we do see quite a significant cytokine release syndrome. Also, we see quite more significant neurotoxicity. Myeloma looks a little bit different, and this particular drug.
I'm very happy about myeloma, having worked in CAR T in the other settings. This CAR T, again, as you saw in the presentation, Dr. Munshi, they actually managed, I would say they managed the cytokine release syndrome very well. I think myeloma doctors can be proud that the people who participated in this trial did exceptionally well. 91% of patients ended up getting tocilizumab with the CRS protecting antibody, and 88% of patients got CRS, most of which was grade 1 and 2. So that was very good. And the neurotoxicity events were also single digits. So these point to the fact that the CAR T is safe, and people have gained so much experience that myeloma doctors are doing a really good job managing their patients who are getting CAR T cells.
Any thought on managing the CRS, use of tocilizumab when one would or would not want to use steroids and other thing? It is less frequent and less intense, so that's a good news.
Yeah.
But we still have to use once in a while
for sure
the measures.
Absolutely. And you know, the American Society of Cellular Therapy, Transplant and Cellular Therapy, has come up with guidelines for the use of grading of CRS and the use of tocilizumab and other agents. Extrapolating from the lymphoma literature and the leukemia literature, use of these agents does not seem to compromise the responses. So in this study that we saw, 90% got tocilizumab, but 100% responded. So I think it is a good sign that cells are expanding in the body and causing CRS, and we are able to, and it's a very good sign that we are able to put a halt to it very quickly with tocilizumab. So I'm an optimist in that regard.
I totally agree. I think we have, and my focus has been myeloma CAR T studies, but having also seen what our lymphoma colleague does, the myeloma CAR T studies in general, and this one in specific, is relatively very well tolerated.
Exactly.
So I think that's a very good, important point. And so if we go back to the process of this particular study, patients got lymphodepletion, and they get lymphodepletion with Cytoxan and fludarabine. And I think Cytoxan and fludarabine has its own toxicity. These are the old drugs we have used for 30 plus years.
Yeah.
And the main problem is cytopenia.
Yeah.
And I think one of the toxicity with this and every other CAR T cell has been prolonged cytopenia. And I think we have to we have to manage it. And managing cytopenia is not new to us. That's part of oncology. However, this is very late stage patients. They could have more prolonged neutropenia, thrombocytopenia, and red cells requirements. So I think that's important. So they get lymphodepletion with these two drugs, and then we infuse the CAR T cells. The dosage of CAR T cell in this study was a little bit different than what we are used to. They use more specific number of transduced cells, right?
Right. So they take the total T cells and they calculate the percentage of transfused cells, and their goal is a weight-based dosing of 0.75 million cells per kilogram body weight. So that ends up in the ballpark of where we are doing with the BB2121, but it is very specifically targeted to the number of transduced cells.
And so overall response rate of 91%, close to almost everybody responding, is a really important point for us. Now, the issue that I would just want to know your personal experience with this. We have any anecdotes or?
I have personal experience with this particular CAR T. Actually, I have to say that all of my patients who went on, as you very well know, I do a lot of allogeneic transplants for patients with late-stage myeloma. And somehow, everyone who ended up was patients who had allo transplant. So they were very late. They had exhausted all available agents, seen them multiple times, and they even had an allo transplant. Just keep going till the next agent became available. And I have also had all of my patients have responded with very minimal CRS or any toxicity. And so far, I'm fingers crossed, patients are all staying in remission. At very early follow-up, I have to say the follow-up is less than 4 months for the shortest follow-up.